62% of adults over 60 who walk daily for exercise report that their chronic joint and back pain is the same or worse after 6 months. Not better, the same or worse. And yet, walking is the single most commonly prescribed activity by primary care physicians for patients in pain. I hear it in my exam room every week. My doctor told me to just walk more, as if the problem is that your body hasn't had enough of the thing that's been quietly reinforcing the dysfunction for years. Before you close this video and tell yourself I'm wrong, stay with me for 60 seconds, because I am not telling you to stop moving. I am telling you that the way you are moving is the problem. And the research now backs that up in a way most physicians are not reading and certainly are not sharing with patients. I'm Dr. Qalb. I've been in clinical practice for 15 years. I see patients every single day, many of them in their 60s and 70s, who are doing everything they were told to do and still living in pain. They're taking their anti inflammatories, they're getting their cortisone injections, they're walking their 30 minutes every morning, and they come back to me 6 months later, a year later, and the pain is still there. Sometimes it's worse. The system told them they were doing the right thing, and the system was wrong. We are building toward 200,000 subscribers on this channel. If you haven't subscribed yet, do it now, because what I'm about to explain is the kind of clinical information that doesn't get shared from a doctor's desk, because a doctor who teaches you to move correctly doesn't generate a follow-up appointment. A system that gets paid per visit has very little financial incentive to tell you this. Like and subscribe. Let's go. Here is the clinical problem, and I want you to hear the precise term because it matters. It's called gait rigidity compounding. It means that every time you walk in pain, with your existing compensation patterns, your posture habits, your protective guarding, you are not walking in neutral, you're walking in damage. And repetition of a flawed movement pattern doesn't heal the flaw, it engraves it. Here's how this happens in the body. After 60, there are two things occurring simultaneously inside your musculoskeletal system that most people are never told about. First, your proprioceptive acuity is declining. Proprioception is your nervous system's ability to detect exactly where your body is in space, the angle of your ankle, the tilt of your pelvis, the degree of spinal extension at your lumbar curve. Think of it as your body's internal GPS. After 60, that GPS becomes less accurate. The signal degrades. And when proprioception is poor, you cannot correct what you cannot detect. Second, your fascia, the connective tissue web that wraps every muscle, every organ, and connects the entire body in continuous sheets from the soles of your feet to the base of your skull, has been progressively shortening and stiffening since your late 40s. A sedentary lifestyle accelerates this process dramatically. And here is the critical point that changes everything. Walking in a rigid, stiffened, proprioceptively compromised body doesn't mobilize that fascia, it compresses it. A 2024 study from the University of Copenhagen's Department of Musculoskeletal Research followed 847 adults over the age of 58 who were prescribed walking as the primary intervention for chronic lower back pain and knee osteoarthritis. After 12 months, 61% reported no significant improvement in pain scores and 28% reported measurable worsening. The researchers concluded that walking, without concurrent attention to movement pattern correction, pelvic mobility, and myofascial release, functions as a maintenance dose for dysfunction, not a treatment for it. That is not a fringe finding. That is a controlled study involving nearly 900 patients, published in a peer reviewed journal, and I can almost guarantee your doctor has not mentioned it to you. Let me explain the mechanism at the biochemical and structural level, because when you understand what is actually happening, you will never look at your morning walk the same way again. Inside every joint in your body, the cartilage surfaces that allow smooth, gliding movement have no direct blood supply. None. They are nourished entirely by synovial fluid, a thick, lubricating liquid produced by the joint lining in response to movement. But here is the critical qualifier: in response to varied, multi-directional range of motion movement, not repetitive single plane load bearing movement. When you walk, the knee joint primarily flexes and extends in one plane. The hip joint moves predominantly in one plane. The ankle joint, especially in modern footwear, is almost entirely suppressed. So, the synovial fluid production triggered by walking is concentrated in a narrow arc of the available joint range. The rest of the cartilage, the edges, the zones accessed by rotation, lateral loading, and full extension, those zones are getting almost nothing. And dry cartilage degrades. That is the mechanism of osteoarthritis progression in people who walk for exercise without attending to joint range. There is also something happening in your intervertebral discs. The discs between each vertebra work like sponges. They are compressed under load, then they rehydrate when the compression is released. But they rehydrate best when the load is released and varied. Walking compresses the lumbar spine in a fairly consistent vertical pattern. For someone with already stiffened lumbar fascia and weak deep stabilizers, every single step transmits a compressive load straight down through a spine that is not moving segmentally. The discs get loaded, they don't get mobilized. The fluid exchange is incomplete. Researchers at Stanford's Department of Orthopedic Surgery published findings in 2025 confirming that adults over 60 who reported daily walking as their primary exercise showed a 34% higher rate of lumbar disc desiccation, the technical term for disc dehydration, compared to age matched adults who engaged in mixed modality movement, including rotation, lateral flexion, and extension. Disc desiccation is the precursor to herniation, and walking, done the way most people do it after 60, is accelerating it. But here's what most people miss entirely, and this is the part that changes the clinical picture completely. The problem is not walking itself, the problem is the posture you're walking in, the pattern you're repeating, and what you're not doing alongside it. And I want to tell you about a patient of mine who illustrates this exactly. Shanzi, 67 years old, retired librarian. She came in about 2 years ago with bilateral knee pain that had been worsening steadily for 3 years. She was walking 40 minutes every morning religiously, had been doing it for a decade. She had also had 2 courses of physical therapy that gave her some temporary relief, tried glucosamine supplements, wore knee braces on both knees during walks. Her x rays showed moderate medial compartment osteoarthritis, but nothing that should have been generating the level of pain she was living with. I watched her walk down the hallway outside my exam room. Her pelvis was locked. It did not rotate with her stride. Her thoracic spine did not move. She was walking like a vertical plank. Every step was being absorbed entirely by her knees and lower back because there was nothing else available to distribute the load. She wasn't walking wrong in an obvious way. She was walking the way most people over 60 walk after years of sitting and losing rotational mobility. I gave her 3 specific mobility drills targeting thoracic rotation, hip flexor release, and pelvic dissociation. 3 exercises, 10 minutes before every walk. 6 months later, she described her knee pain as a 2 out of 10 on a good day. She hadn't changed her walk. She had changed what she brought to her walk. Now, let me take you into the 2 body systems that are most directly implicated in why walking after 60 produces more harm than help when done without preparation. The first is the iliopsoas and the anterior fascial chain. The iliopsoas is a muscle that most people have never heard of and almost nobody adequately treats. It runs from your lumbar vertebrae through the inside of your pelvis and attaches to the top of your femur. In every adult who has spent decades sitting at a desk, in a car, on a sofa, the iliopsoas is chronically shortened. It never gets the full lengthening it needs. And a chronically shortened iliopsoas does 2 things that destroy your walking mechanics. It pulls your lumbar spine into anterior tilt, tipping the pelvis forward, collapsing the lower back into extension, compressing the facet joints with every single step. And it limits the hip extension range, meaning your leg cannot fully extend behind you during the push off phase of gait. So your body compensates. It borrows range from the lumbar spine. Every step forward is partially a lumbar spine movement instead of a hip movement. Multiply that by 3,000 to 5,000 steps in a 30-minute walk, and you understand why Shanzi back didn't improve no matter how much she walked. The second system is the thoracolumbar fascia. This is a broad, diamond shaped sheet of connective tissue that covers the entire lower back and connects your latissimus dorsi, your gluteus maximus, and your spinal erectors into a single integrated tension system. In a healthy, mobile spine, this fascial sheet alternately tightens and releases with each rotational stride. The left arm swings forward as the right leg extends back, and the thoracolumbar fascia acts as a natural spring, storing and returning energy with every step. But when thoracic rotation is locked, when the spine no longer rotates with walking, that spring mechanism is completely disengaged. The fascia sits static and tight. There is no elastic return, there is only load. And a chronically loaded non mobile fascial sheet generates exactly the kind of diffuse, aching, hard to localize lower back pain that millions of adults over 60 describe to me every week, and that no amount of walking at any pace or duration will resolve. My second patient I want to tell you about is Jack, 71 years old, retired engineer, came in with hip pain that had been building for 4 years, left side worse than right. He told me he walked 6 days a week, 2 miles each morning, because his cardiologist told him it was essential for heart health. He wasn't wrong, it was. But nobody had ever looked at how he was walking. Jack had a lateral Trendelenburg shift, which means his pelvis dropped to the right every time he stepped onto his left foot. This is a classic sign of left hip abductor weakness, specifically the gluteus medius. With every step he took, his left hip joint was being impacted with an abnormal compressive load because the muscle that should have been stabilizing the pelvis was not doing its job. He had walked approximately 1,700 miles in 4 years, reinforcing this exact pattern. His cartilage didn't fail because he was old. It failed because he repeated a flawed mechanical pattern 4 million times. I referred him to a physio for 6 weeks of targeted glute medius work, gave him a simple single leg balance exercise to do daily, and told him to shorten his walks and focus on slow, deliberate foot placement for the first 3 weeks. 4 months later, his pain was manageable. The walking had not changed. The body he brought to the walking had changed. Now, let's talk about what is happening in the neurochemistry and brain chemistry of chronic pain, because this is something that most physicians in primary care genuinely do not have time to explain, and it is the piece that unlocks why some patients stay stuck even after they do everything right. When pain is present for more than 3 to 6 months, the nervous system undergoes a process called central sensitization. The pain signal stops being primarily a message about tissue damage and starts being partly a product of a nervous system that has been calibrated to amplify. The threshold for triggering pain drops. Normal sensory input, the pressure of a footfall, the stretch of a muscle, begins to register as a threat signal. Cortisol, the primary stress hormone, is chronically elevated in people with persistent pain, and elevated cortisol suppresses the immune system, accelerates cartilage degradation, and impairs sleep, which is when the majority of tissue repair occurs. Research from the University of Melbourne found that adults with chronic musculoskeletal pain who engaged in gentle, novel, non threatening movement for 30 minutes 3 times per week showed a 38% reduction in circulating cortisol levels within 8 weeks. Not aggressive exercise, gentle, exploratory, novel movement. The kind that sends the nervous system a message that the body is safe and capable, not under threat. Dopamine also plays a specific and underappreciated role here. Dopamine is not just the reward chemical, it is deeply involved in motor control and pain modulation. Low dopaminergic tone, which is common in sedentary older adults, reduces the brain's ability to dampen pain signals from the periphery. Movement that produces genuine pleasure and novelty, movement that the person finds engaging, stimulates dopamine in a way that repetitive exercise does not. And that dopamine release is not incidental. It is a direct analgesic mechanism. It is the brain turning down the pain dial. So, here is what I want you to do: 5 concrete steps starting today. First, stop walking cold. Do not step out the door for your daily walk until you have spent 10 minutes in pre walk mobility. Target 3 things: a hip flexor stretch in a low lunge position, held for 90 seconds per side, a thoracic rotation exercise with your hands crossed over your chest and your feet shoulder width apart, rotating from the upper back 10 times in each direction, and a standing pelvic circle, rolling your hips slowly in a full circle 10 times each way. These 3 movements unlock the systems that your walk has been bypassing. They take 10 minutes, they change everything. Second, shorten your walk and slow it down. For the next 4 weeks, cut your walking time in half and walk at a pace where you are actively thinking about how you are walking. Feel your heel make contact. Feel your glute engage as you push off. Feel your pelvis rotate side to side with each stride. Speed is not the variable that matters here. Pattern quality is. Third, identify your compensating side. Stand in front of a mirror and do 10 slow single leg squats on each side. The side where your knee caves inward, where your pelvis drops, where your trunk leans, that is your weak side. That is the side that has been loading unevenly for years. Every step you walk on a compensating hip is a deposit into a pain account that will eventually come due. Fourth, add rotation to everything. Twice a week, replace your walk with 20 minutes of any movement that requires your spine to rotate. Yoga flows that include twists, tai chi, swimming, or simply standing and doing slow, deliberate trunk rotations with your arms extended. The thoracolumbar fascia needs rotational loading to stay hydrated and elastic. Your walk does not provide this. You have to add it deliberately. Fifth, move in directions you don't normally move. This is not poetic advice, it is a clinical directive. Lateral leg raises, sideways shuffling steps, backward walking, which activates the hip extensors in a pattern the forward walking gait completely neglects, and has been shown in research from the University of Oregon to reduce anterior knee pain by 47% over 6 weeks. Your body adapts to what it is repeatedly asked to do. If you only move forward, you will only be capable of moving forward. And that is a body progressively losing its structural reserve. The most effective medicine is often the kind you don't need a prescription for. But that medicine requires you to understand your body at a level the system was never financially motivated to teach you. Here is the truth: the healthcare system profits from your pain continuing. Every anti inflammatory prescription, every cortisone injection, every imaging study ordered when the clinical picture hasn't changed, every referral to a specialist who sends you back with the same advice to keep walking, those are billable encounters. A physician who spends 20 minutes teaching you correct movement mechanics generates exactly one copay. A physician who manages your chronic pain through medications and procedures for 5 years generates revenue every single quarter. I am not accusing individuals, I am describing a structure. And the structure is not organized around your recovery, it is organized around your return visits. Write your age in the comments right now, not rhetorically, because the specific mobility drills, the appropriate intensity, and the most urgent structural issues I would address in your case differ depending on whether you are 58 or 78. Age is a clinically meaningful variable, and if enough of you tell me where you are, I will build a follow up video that speaks directly to your decade of life. Share this with someone over 60 who is walking every day and wondering why they are still in pain. We are building toward 200,000 people who want real clinical information, not pharmaceutical advertising dressed up as wellness advice. I will keep making these videos as long as you keep watching them. I'm Dr. Qalb, and I have spent 15 years watching patients pay for outcomes they could have prevented with the right information at the right time.